on this Sunday morning. Thank you for being here. I know it's a challenge to get things activated at 11 in the morning on a Sunday, but nonetheless, let's start today's talk. It's on newer genetic tests and what is their role and relevance in fetal medicine. So it's very basic, and I thought I'll take you through right from systems biology onto the various kinds of tests that are available. So we know that fetal abnormalities are identified in about 2 to 5% of pregnancies, and they are responsible for 21% of perinatal deaths. And the outcome, if a fetal abnormality is identified in pregnancy, and the prognosis of that particular abnormality would depend, of course, on the nature of the abnormality, whether it is isolated or there are multiple malformations, and if it is of a possible genetic etiology or it's an isolated malformation, which is a developmental malformation, or it's because of some intrauterine infection. So, what are the indications of genetic testing in fetal medicine? The commonest, the ones we encounter on a daily basis, is a positive aneuploidy screen. There could be a family history of a genetic disorder, like somebody with intellectual disability, somebody with beta thalassemia, hemophilia, Duchenne muscular dystrophy. These are just to name a few common ones. Or the couple are carriers of a genetic disorder, which we test for as a part of preconception counseling, and that is beta thalassemia. And now we realize that more and more we need to test the carrier status for spinal muscular atrophy, because the carrier status of that is 1 in 50. Or if there are fetal malformations that are identified on an antenatal scan, or there is intrauterine fetal demise. There could be a couple that are not there, but I've just penned down some of the common ones. So, what genetic disorders are we testing for? To put it very simply, we would look at two categories of disorders: chromosomal disorders and single gene disorders. So we are very familiar from our school days as to what the chromosomes are. They are present in every cell in the nucleus of the cell, and they are 23 pairs. And when we put them like this in a very specific order, from the tallest or the biggest one to the smallest, which is chromosome 22, in chronology, actually 21 is smaller than 22, but it's put like this. And the two sex chromosome, be it XX or XY, it is called a karyotype. I'm a female, I believe in females, so I always put XX. I think they're super women. So we come on to the first group of disorders, and those are the chromosomal abnormalities. So there are abnormalities that are present in one of these 23 pairs. So there could be abnormalities of number, like those, like Down syndrome, trisomy 13, trisomy 18. It could be, so this is abnormality of number, which is an aneuploidy. It could be a triploidy, where the entire 23 pairs have an extra one. Okay, so this is triploidy, where every chromosome has an extra member. Or it could be a monosomy, where one of the chromosomes is absent, and this is commonly Turner syndrome. So we see these three situations fairly commonly: triploidy, trisomy 21, or trisomy 13 or 18. It could be for any chromosome. The other ones are so significantly abnormal it ends in either an intrauterine death or a abortion. And this is Turner syndrome. On the other hand, we could have abnormalities of structure. And these abnormalities of structure is when there is something which is not quite the same in the formation of that chromosome. Now, this is a schematic diagram. We know that, as you see here, if I go back to this slide, every chromosome occurs in pairs. One comes from the mom and one comes from the dad. So here, in one of the chromosomes that has come from either the mother or the father, it's not identical to the other one. There is a change because one part of another chromosome has come here and this part has gone there. So this is called a translocation. It's just translocated between two chromosomes. They are not in their appropriate place, but nonetheless they are all there, and that is why it is called balance. So all the genomic material is there, it's just rearranged. In some situation, and this will not cause a problem in the person who carries that balanced translocation. In some situation, it can be unbalanced, whereas something can either be deleted or it can be added, and it could be what we call a derivative chromosome because of multiple exchanges. Now, here there is either missing genomic material or extra genomic material, and that is why they are referred to as unbalanced uh, translocations. They could be translocations, they could be inversions, they could be anything. And it's not important. It's just important to remember that they could be unbalanced. And this unbalanced group is the one that would present with abnormalities. Or remember, all chromosomal abnormalities postnatally would present with intellectual disability, except for Turner syndrome and to some extent Klinefelter syndrome. Otherwise, antenatally, they may manifest with growth restriction or fetal malformations, and postnatally, they manifest with intellectual disability. Now, this is from one of our patients just to show you what an unbalanced karyotype looks like. You can see that this is chromosome 18. This one is slightly different from this. It's pair. Normally, they all look the same. So here, there is something missing here. And this is longer than this one, and there is something added here. So this is an unbalanced uh, karyotype. Whereas if you look, so this was what I had showed you, and if you, sorry, that was a balanced one. My apologies. This is the unbalanced where you have the extra chromosome here. So you have one chromosome 18, two chromosome 18, and three chromosome 18. And this is inherited from a balanced translocation carrier because this part which is missing is already gone here. So instead of being here, it is here. We know that she's balanced because she's an adult, she's absolutely normal, and we did her karyotype because the fetus had some malformations. So a translocation carrier is usually picked up because of the obstetric history or because the fetus or because her child has intellectual disability or dysmorphism or malformations. So now we come from this bit. So I said they were all in the nucleus. These are the chromosomes. Sorry, Harish, I forgot to ask you, is everything okay?
Ma'am, it's perfect. You can
Okay,
continue, ma'am.
thanks. Um, so this is the nucleus. These are the chromosomes that are present in the nucleus. And when we open up this chromosome, we get this double-stranded DNA molecule. And this double-stranded DNA molecule, if we think back to what we learned in school, is made up of four nucleotides, ATGC. Okay, so this is what is here. It's only magnified. So there are ATGC in varying combinations that make up this double-stranded molecule. And this is what constitutes the gene. So this is just showing you what it all means. We saw the chromosome. So this is a chromosome. We open up the chromosome. It is made up of the double-stranded DNA molecule. And this double-stranded DNA molecule, in its various combinations of the four nucleotides of which it is made of, ATGC, comes together to form different genes. And on all our chromosomes, the 23 pairs of chromosomes, we have 20,000 genes. Okay, so that's clear. So it's fascinating to understand that it's all present here. This is the compressed version of our genomic material, and this is the open version of our genomic material. And this is the base of what it's all made up of.
Ma'am, sorry to
Now,
interrupt.
yeah.
Ma'am, the viewers are not able to see your the pointer.
Oh, so I should not use it. Okay.
No, they want to use it, ma'am. They would want to show the portions that you're referring to.
But I'm
Uh,
using, what should I do?
yeah,
I'm
can you
using my,
can you just exit the slideshow option, ma'am, and then make the screen smaller?
exit the slideshow. What how? Okay.
In the
I,
PPT, it's a PDF, right?
yes.
Okay, if it's a PDF, okay. Is there
Should I?
any other pen tool that you have, ma'am, that you can probably point out and show?
So does this work? Does this work? If I point it with a, I'm
No,
not
ma'am. It
sure.
should be in your.
So
Uh,
should I put up my slides? Will that be better?
yes, ma'am. That should work.
I
But your animations will not. Okay, that's okay, ma'am. No problem. You can carry on. Carry on.
I don't know how to take the pen tool out of this.
Oh, no problem. Carry on, ma'am. Please carry on.
Tool. Should I look on top somewhere? Uh,
1 second, ma'am.
I. How do I take out that pen?
Just 1 second, ma'am. I'll tell you. 1 second.
Because I was using the cursor of my laptop, but that's probably not showing. Hello?
Yes, ma'am. Ma'am, on the top right of the Mac preview application,
On the top right of the Mac, yeah,
there is a pen tool, ma'am.
of my computer, of my
Yes,
Mac
yes,
computer.
ma'am.
Where is a preview?
Ma'am, I think we can carry on, ma'am. It's okay. You can carry on. Please carry on.
Okay. I'm sorry, I'm not familiar with all this.
No problem, ma'am. Please carry on.
So if we come, so I'll say it so that you all understand, since you can't hear my see my pointer. So if you see on the left side of this slide, you have a chromosome. So that is the the constricted or the very highly contracted part of our genome. This opens up to form the double stranded DNA molecule, and this double stranded DNA molecule is made up of varying combinations of ATGC that come together to form the genes. In the genes, you can see we have these exons. So you have these various exons that have, in between the various exons, you have the introns. So finally, when we are doing our tests, remember this slide, because we are looking for abnormalities of chromosomes, and then we are opening up that double stranded DNA molecule and looking at the genes to look for abnormalities for monogenic disorders. And within the monogenic disorders, most of the times we only look at the exons. So this is very important, this base to understand. And that's how you're then going to understand what the various tests are looking into. So this bit is the chromosomal disorders. And when we look at the lower part of the slide, we look for abnormalities there. You look for the single gene disorders. Now, in this slide, I've just put together the different kinds of prenatal genetic tests that we do. What is the turnaround time, the nature of the test, and what does it identify? It's just a little bird's eye view. Now you know that when we look at chromosomes, we can either do the fluorescent in situ hybridization, in short, that is called FISH. We also do the QF-PCR, which is a molecular form of FISH. We can look at the cell-free DNA molecule in the maternal blood, and we do a karyotype and a microarray. So these all first 4-5 technologies look for abnormalities in the chromosomes. Now, the FISH, the turnaround time is 2 to 3 days, as it is for QF-PCR. It's very targeted. The mind needs to know what to order. So we do a FISH commonly in fetal medicine for chromosomes 13, 18, 21, or sex chromosome abnormalities. Sometimes, if you've got a chronotruncal abnormality and you want to do just one test, you would do a 22q microdeletion. So you need to know what to look for, and then you order the test. Cell-free fetal DNA, it takes about 10 to 14 days. We do it if there is a screen positive, and again, it only looks for abnormalities of 5 chromosomes. Remember, traditionally, all these tests were really, they went into research to look for abnormalities of chromosome 21 because trisomy 21 occurs in about 1 in 1,000 live births, whereas 13, 18 are extremely rare. Most of the times, you can pick up abnormalities on the ultrasound. In trisomy 21, it's not necessary that you pick up abnormalities on the ultrasound. Then we come on to the karyotype, which is what I'd shown you. And that takes about 14 days because the cells have to be cultured. And that's what takes time in a karyotype. It's very, very labor intensive. We look at the 23 pairs in the magnification I showed you. So it only picks up abnormalities of number. It'll pick up all abnormalities of number. And within the abnormalities of structure, it will only pick up those that are more than 10 million base pairs. Then we come to the next row, which is chromosomal microarrays. Now, chromosomal microarrays, if you've got good DNA in the material, it's a quick test. It looks at copy number variations. I'll be coming to what this term means. And it looks really for abnormalities of structure which are smaller than those that are picked up by the karyotype. So it's about up to even 20 kilobases. There we were talking about million bases, and here we are talking about kilobases. So it can pick up very, very small abnormalities. Sometimes if the amount of DNA is not enough, the cells have to be cultured before the DNA can be taken, and that is why you might need additional time for the return of the test. Now remember, these are not turnaround times which are practical 3 to 4 days, because the sample will go into a lab, the DNA will be extracted, they might need to pool samples together. So tentatively, we take about 2 weeks as a rough turnaround time for direct chromosomal microarray analysis. Okay, these are just in labs where nothing else is happening, this 3 to 4 days. Then we come on to the molecular based tests. For example, you have beta thalassemia, you have hemophilia, you're just targeting one gene. That result can come back anytime between 7 to 14 days. It looks at single specific genes and at specific mutations within those genes, because always for prenatal diagnosis, you need to be very sure as to what you are testing. You cannot look at a needle in a haystack in prenatal testing. And then comes in the new lot of tests, which are the next generation sequencing. And I know there will be a lot of queries related to that because these are tests that are highly promoted. And I've spent a couple of slides subsequently to talk about these tests. They could be panel tests, they could be whole exome. They look at multiple genes together because I'm not sure what phenotype my fetus has. And hence, I want to test multiple genes that could be related to the phenotype of that fetus. And this really again looks at Mendelian disorders or monogenic disorders that occur because of abnormalities in genes. So, what test to order from this huge armamentarium of tests really depends upon the indication for that test. So, look at this case where at 28 weeks of gestation, there was polyhydramnios and a double bubble on the ultrasound. You all know better than I do that this is duodenal atresia. Now, for duodenal atresia, we know you find one malformation, you have to look for additional malformations. You would do a fetal echocardiography because 30% of these cases could be because of Down syndrome. Even at 28 weeks, it's important to understand because accordingly, the management, the counseling, you prepare the families. You don't say, okay, we have a malformation, we'll wait till the baby is born to understand what to do and why the baby has this. But what test are we going to do at 28 weeks? If this was something you had identified at the 18 to 20 week scan, you would have done a FISH and a karyotype, or a FISH or a microarray. At 28 weeks, I would do a FISH. I may keep a sample for a microarray, but if I get my answer in a FISH, because I know predominantly duodenal atresia is only associated with Down syndrome, and I get my answer in that, I would not take it forward. But at 28 weeks, we cannot do a karyotype because it's difficult to culture those matured amniotic fluid cells. So when I do a fish test, I will look at only the 5 chromosomes that are in their boxes, 13, 18, 21, and the sex chromosomes. I don't tell the sex chromosomes in the fetus unless there is an abnormality. And this is what on the left hand side the fish test looks like. You are hybridizing with colored uh, probes, and that's why you get these colors for different chromosomes. And this shows 3 orange, which is trisomy 21. On the right side, I've shown you a similar test with QF-PCR, and this is a molecular based test. It doesn't matter whether you do the fish or the QF-PCR, the lab where you are sending your sample will guide you. It depends upon what their expertise is. In my lab, if I'm doing an amniocentesis, we like to do a fish because their hands are set on a fish for the last 30 years. However, if I'm doing a CDS, in that case, if I'm, say, testing for beta thalassemia and the fetus then is affected, the story stops there. But if the fetus is not affected, then in the same DNA sample, we take forward the QF-PCR to check if the baby has or does not have abnormalities of number for these 5 chromosomes. So, if we talk about karyotype as a whole, because remember, for exceptionally few, except for very, very few circumstances, a standalone fish or a standalone QF-PCR is not a good test. You're doing an invasive procedure, you're giving the lady a little risk of abortion. It's good to get the maximum information that you can. Of course, within what is relevant for that specific case. Every test is not applicable for every indication. Remember that, please. So, the indication for a karyotype would be a screen positive, but either by a conventional screen or your so called NIPT test, which is traditionally called the cell free fetal DNA testing. If you have a previous child with Down syndrome or trisomy 13, 18, you know that there's a 1% risk of recurrence in the next pregnancy. A karyotype is enough. Malformations that are consistent with aneuploidies, like a double bubble or a cystic hygroma or something like that. Then we come to the next lot of chromosomal tests to look for abnormalities of number as well as structure, and that is chromosomal microarray. So, what is this DNA microarray? Now, it's very similar to something like a computer chip, where you know that it contains all the features and that circuit on that little piece of 1 inch by 1 inch. Similarly, an array contains all the genomic material. It's an assembly on a slide, things that are spotted on a slide, the important parts of the genome that from literature we know that we need to look for. And on that slide, then we put up sample and we look that is it similar to the genomic reference or is there some difference from the genomic reference? So what it detects are copy number variants. Copy number variants are micro deletions and duplications. Remember we talked about deletions and duplications in a karyotype, but they were large ones. When I want to look at very small ones through a magnifying glass, I do a chromosomal microarray analysis because I can pick up things as small as 50 to 100 kb compared to what we saw in a karyotype, which is up to 10 MB, million bases. Only anything which is more than 10 million bases you pick up in a karyotype, but very small ones you pick up on a microarray. The advantage of a microarray is it identifies all abnormalities that are detected by a karyotype, and it will also pick up additional abnormalities. The only things that a microarray cannot pick up are balance translocation. It can only pick up imbalance. So that's why it cannot pick up balance translocations. But I'm not worried in fetal life because a balance translocation will not cause an abnormality. And it also cannot pick up very, very low level mosaicism. But it's also important to remember that every copy number abnormality that is picked up is not abnormal. Lots and lots of them are benign. If we do our own microarray analysis, which we should not be doing, we pick up many microdeletions and duplications. But we say they are benign because we are normal. And these benign microdeletions and duplications are only responsible for the variations that we see amongst different members of a population. So it's very important because I see many cases where any sort of CNV results in a termination of a pregnancy. So please be extremely careful. Then we come to a situation. Okay, so this is a clinical case that I was coming at. You can see this. This is the fourth pregnancy. Two children are okay, but the second pregnancy was terminated for malformations, hand and foot, and that's all we know. No testing was done. Now, in this current pregnancy, which is the fourth pregnancy, again there were fetal malformations present that were multicystic dysplastic kidneys. Now, when we have fetal malformations, we know the first thing that we need to do is to look at abnormalities of the chromosomes. So, a chromosomal microarray was done. It was difficult to think on this basis as to what we could be thinking of, but we just follow the chronology that is laid down, the guidelines that are laid down, and that is that when there are malformations, we need to do a chromosomal microarray to look for abnormalities of number or structure. And here we found to our surprise 22q11.2 deletion. This is the spectrum of the 22q microdeletions. And that would have explained what was present in the first child. In the second pregnancy, that was discontinued because of limb malformations, and what is even present in this baby. And once I identify a microdeletion, especially for 22q, only really for this, I would test the parents. Because it's happened in two babies, it is obvious that one of the parents could be a carrier. And specifically for 22q, we know that we could have absolutely asymptomatic carriers. But the implications are very high that there is a 50% chance of recurrence in each pregnancy. Every microdeletion doesn't have to be tested in the parents. Obviously, it is different for different microdeletions. So this is another case which I just put up here to tell you another utility of the microarray. So we did a karyotype for a positive screen and identified this one little chromosome which we could not identify or place anywhere within this 23 pairs. So we call this either a marker chromosome, that was the older terminology. Now it is called ESAC, which is an extra structural abnormal chromosome. You don't know the origin on a karyotype. So we do a microarray. And when we do a microarray, we understand that the origin of this marker chromosome is from chromosome 15. And this is just an additional part of chromosome 15, resulting in a 15q11 to 13 duplication. These are just terminologies. Actually, at the beginning, I think I forgot to tell you that when you see a chromosome, it has a constriction in the center. If you look at any one chromosome in the picture here, the upper part is the P arm or the petit arm, and the lower part below the constriction is the Q arm. So this is chromosome 15. If you look at row 3, number 3 chromosome, this is chromosome 15. This chromosome does not have a very significant P arm. It predominantly has a Q arm. So that is why this duplication is of the Q arm. And these numbers are the different numbers on the chromosome. So that is why it is 15q11 to 13 duplication syndrome. And this is associated with intellectual disability and developmental delay as the child grows up. In the olden days, before we had chromosomal microarray, we knew that a large number of these ESACs originated either from chromosome 15 or chromosome 22. So we used to do FISH tests that were targeted to these regions. Also, I want to tell you now that every ESAC is not abnormal. Some of us could be carrying ESACs and are normal. So in this situation, if the microarray is normal, I would also do a karyotype of the parents to see if one of them carries it in a mosaic form. So when we talk about copy number variations, I told you they are microdeletions or duplications, and enumerated here are some of the common microdeletion or duplication syndromes. The commonest being 22q microdeletion. These are the older names. We don't say that anymore. Or a 15q11.11 to 13 deletion, which is Prader-Willi, Angelman, etc. So, what are the advantages of a microarray? The microarray will identify most abnormalities that are detected by a karyotype. It will also identify additional chromosomal imbalances. But remember, if I've done a microarray, it's not as if I can say that I've identified all genetic disorders. There is no test in the world like that which will identify everything. Because I know that a microarray only looks at chromosomes, it does not look at those 20,000 genes inside the chromosomes. So it will not test for monogenic disorders. It's important to understand that. The advantage over a karyotype is quicker because it can be done on uncultured specimens, and hence we can use multiple tissues that we cannot use for karyotype. We can do a microarray sometimes from even tissues that are not alive, and therefore the sensitivity or the uptake, the ability to do a microarray in fetuses with intrauterine death and stillbirth is much higher than the karyotype. In a karyotype, if there are positive results in only 50% of cases, whereas in a microarray, we are able to take out DNA, you are able to do the test. So, what is the diagnostic value of a chromosomal microarray after a normal karyotype? This was the seminal study in 2012 that was published in the New England Journal of Medicine by Ratna et al., where they did a lot of where they had this huge cohort in whom they did karyotype, and where the karyotype was normal, they did microarray. And from that, it stands out that in fetuses with abnormalities that are present on the ultrasound, in 6 to 13% of cases, they will pick up pathogenic abnormalities. So the key word here is pathogenic abnormalities, where a karyotype is normal. And even if it is done in situations where there is no fetal malformations, but you're doing an invasive test for something like an advanced maternal age or a positive screen, in 1 to 2%, you can get pathogenic CNVs in these situations. But remember, every test has its limitations. Some types of chromosomal microarrays cannot pick up triploidy. These are the ones which are based on array CGH. I will be coming to the differences between array CGH and SNPs. It cannot pick up balanced structural malformations or low level of mosaicism. There is something which is referred to as variations of unknown significance or VUS variations. It's either called VUS or VUS. It's very important to counsel patients about that. We don't understand everything about the human body. Similarly, there are some abnormalities that we identify on a microarray, which we don't know whether it's associated with an abnormality or it is just a normal variation, because there is not enough curated literature about that specific variation. This does occur in about 1% of pregnancies, and it is very challenging then to counsel these women. We can get various incidental findings that are unrelated to what we are testing for, and these also have to go into our pre-test counseling. And last but not the least is the cost of a microarray. And more than the cost, I think it is the complexity of data interpretation. And this changes on a day to day basis. More and more software comes up, more and more information comes up through published literature, and you really need to keep updated for all of these. And hence, before you order a microarray test in a fetus, the family must undergo pre-test counseling to understand what is it that is being tested, what are the advantages and the limitations of that specific test. So now we have varying committee opinions. The microarray has been used for long, and these are committee opinions of the ACOG and the Society of Maternal Fetal Medicines as to where we can use a microarray. It is where a fetus has more than one or more than one major structural abnormality. Sometimes you can use it also in a structurally normal fetus who's undergoing invasive testing, or if you have a IUFT or a stillbirth where a cytogenetic examination is indicated. It's important to remember that these tests are not limited to situations of advanced maternal age. Advanced maternal age is only associated with an increased baseline risk of trisomy 13, 18, and 21. Copy number variations, which are these microdeletions and duplications, are not associated with advanced maternal age. There are various guidelines for testing for laboratories. I'm not going to go into those details, but just to let you know that as there are guidelines for managing the fetus and in whom to do the test, there are also guidelines that are laid down for the laboratories as to how and what test they should perform and what is the quality control that they need to follow. I've just got a slide because there's always a lot of confusion between array CGH and SNPs, or in all the times that I've spoken about this technology. Remember, the technology is comparative genome hybridization. I have two sets. I have normal, I have abnormal. I give them different colors so I'm able to identify what is lost and what is gained. Okay, that is the basic technology of comparative genomic hybridization. Each word is self explanatory. Now, the new ones is, so we've spotted this technology on a slide, and now on the slide, they are using various oligonucleotides or molecular probes that are there, and they're just putting the patient sample. And if they're using something which is called SNPs, so remember they are just different ATGCs that they are using there on the arrays, it is called a SNP array. And for both of them, this is what we identify. Remember, most of it is normal. So this is 0, log ratio 0. It's normal. Your reference and your patient sample is normal. But here, there is a little dip. In this part, in your patient sample, something is missing, and this is a microdeletion. Whereas in the lower slide, section of the slide, where the black is, something is extra, and that is gone up. So that is a microduplication. There are some advantages of SNP arrays. It can pick up even smaller microdeletions because, it's looking at smaller things. It can pick up low-level mosaicism. It can pick up triploidy. It can pick up something which we call uniparental disomy, which is important for some disorders, which are what we call those that occur because of genomic imprinting, like Prader-Willi, Angelman, Wiedemann-Beckwith, Russell-Silver. These words are relevant because when we see an omphalocele, we want to think about Wiedemann-Beckwith syndrome. And it also picks up what we call long contiguous stretches of homozygosity. Remember that these per se are not abnormal. But if we have consanguinity, if we have endogamy where people are marrying within the same communities, and there is some sort of a monogenic disorder that occurs in that family because of a single gene, then it can guide us to look for genes within this. But here you would need a geneticist to take this forward. But no pregnancy should be discontinued because of the finding of long contiguous stretches of homozygosity. And at this point, I would also like to say that pure the CGH arrays are no longer used. Most of the array systems that we use now are a combination of probes, which are the array CGH probes, where you have the common microdeletions along with SNPs. So you can pick all these up. If we use the very, very low density microarrays, then they don't have SIPs. So that is where you would miss triploidy. Okay, so that's where you miss triploidy. But remember, whenever you're doing a prenatal test, you're doing some sort of maternal cell contamination. And if you're using QFPCR, ask your lab whether that would pick up triploidy. That would pick up triploidy. So don't worry too much there. So when we compare karyotype, the CGH array, and the SNP array, so this is putting it very simply, all of them will pick up aneuploidy. Balanced translocations is only picked up by a karyotype. Unbalanced translocations, so they are big ones, big abnormalities, are picked up by all. Triploidy is picked up in a karyotype and it is picked up in a SNP array. It is not picked up in a pure CGH array. Large areas of loss of heterozygosity is only picked up in a SNP array, but that should not worry you in prenatal diagnosis. And copy number variations, which are small microdeletions and duplications, are picked up in a CGH array and a SNP array. I hope I'm clear here. Okay, so now we've talked about abnormalities of chromosomes. You can see it on the left side of the slide. We've moved from karyotype to microarray. In between, we have FISH or QFPCR, which is targeted. And on the right hand side, we now want to look at genes. And I can see that I'm also running out of time, so I'm going to move a little faster. We're also looking at genes now because we've opened up our chromosomes and we're looking at abnormalities within single genes or multiple genes together. And this is for Mendelian disorders or what we call monogenic disorders that occur because of abnormalities of single genes. So we have a situation. These are the common situations which occur because of abnormalities in genes: thalassemia, SMA, deafness, albinism, the various inborn errors of metabolism, achondroplasia, tuberous sclerosis, DMD, hemophilia, and mental retardation, which is a phenotype which can occur because of abnormalities in one of 700 odd genes. So I give no talk to fetal medicine specialists and obstetricians without talking about thalassemia, because we still get patients in advanced gestation. Only yesterday I've seen somebody at 21 weeks of gestation who are now identified to be beta thalassemia carriers. At this point in time, I would put it down to COVID, but I think each one of us are responsible for this. And we all need to, like you order the array of HIV, HPSAG, etc., to please order HPLC, hemoglobin A2, along with a complete blood count. And this is a couple who both are carriers. Don't go by the hemoglobin alone, because you can have a normal hemoglobin in beta thalassemia carriers. So we look at a RBC which is increased for the hemoglobin. We look at low levels of MCV and MCH, and we look at an elevated hemoglobin A2. You need to use a lab, or you get the lab wherever you are sending it, to make sure that your HPLC hemoglobin A2 report gives a combination of hemoglobin, RCV, MCH, and MCV. You can change your labs. I remember 20 years ago, most of the labs, including Lal's and Ranbaxy, were not doing CBC along with hemoglobin A2. It was only when we repeatedly wrote back to them that please incorporate this. Now you see the HPLC A2 reports have this. Because sometimes you get borderline levels, and unless you have these parameters along with it, it's very difficult to make a conclusive diagnosis. So there we saw that both couples were carriers for beta thalassemia. Now, here we know that there is a 25% risk to the baby for beta thalassemia major. In 75% of the cases, the baby can be normal. So we need to do a CVS to make sure that the baby does not have beta thalassemia major disease. And how do we do that? We have to first identify the mutation in the couple in the beta globin gene. One disease, one gene. We test the parents, identify that one mutation in the gene, and we test for that one mutation in the fetus. It's not correct or appropriate to start testing the fetus without knowing what we are testing for. Because remember, the fetal sample is limited, it is precious, it's an invasive test. So you need to target the right spot when you're doing prenatal testing. So this is the situation: one disorder, one gene, you test that one gene by PCR-based test. We have a second situation where a phenotype is caused by mutations in one of many genes. Like I alluded to before, mental retardation is one of them. It could be because of so many monogenic disorders after we have excluded chromosomal disorders. Fetal anomalies like recurrent polyhydramnios, hydrops fetalis, renal agenesis, arthrogryposis. There are so many causes that cause these phenotypes. These are phenotypes. So I cannot do a prenatal diagnosis for mental retardation. I will need to know what caused that mental retardation and then do the prenatal diagnosis. So herein comes our rescue of this new technology, which is called next generation sequencing. Next generation sequencing is a method where I can look at many genes together. What I spoke to you about before is I know it's beta thalassemia. I will look at that one beta thalassemia gene, which is the HBB gene. But in situations where I don't know where I'm looking for, I want to look at either all the 20,000 genes in the genome, which is called exome sequencing, because we are looking at the exons. If you go back to my slide on the genes, the gene is made up of exons, which really makes the proteins. So I do exome sequencing, or I can look at some related panel of genes. For example, if I suspect Noonan syndrome antenatally because of either, you know, increased nuchal fold thickness or renal abnormalities or pleural effusion, I can only look at the 17, 18 odd genes that are associated with Noonan syndrome. And that is called panel testing. Okay. So the different colors in the slide below are different panels. If I test them all together, that is exome sequencing. If I'm doing exome sequencing antenatally or after a pregnancy is terminated for a malformation and I want to understand why that malformation occurred, it's better to do a trio whole exome sequencing because we generate a lot of data within gigabytes. And from that data, I want to sift out what is rubbish and what is relevant. And to be able to do that, if I do the fetus and the parents together, it is easy rather than doing only the fetus. But if I'm only doing panel testing, I'm fine in just doing the fetus together. And there are various studies in literature, in published literature, that quote very varying diagnostic rates that range from 6 to 80%, depending obviously on the sample size. If the sample size is small, because that's how it all started, with sample size of 5 and 10 and 15, the diagnostic rates are higher. And if your sample size is more, the diagnostic rates are lower. We've had two major studies that were published earlier this year or last year in the Lancet, which which really did exome sequencing of thousands of fetuses, and they had a diagnostic rate of about 10 to 13%. In my department, one of our students has also done exome sequencing, trio exome sequencing in 60 fetuses, and we got a diagnostic rate of about 40%. So it varies depending upon the indication for what you are doing the test for. Now, this is one example from the series of my department, where this was a second gravida. The first child had multiple malformations, had died, and nothing was done. In the current pregnancy, the initially things were okay. In the level 2 scan, the nuchal fold thickness was increased. In the third trimester, there was progressive ventricular dilatation and fetal growth restriction. You can see it in the scans here. There was Dandy-Walker malformation. The pregnancies were terminated because 2 fetuses were affected, and obviously one thought of a genetic etiology. There was arthrogryposis on examination of the second baby after delivery because we saw the second baby in the department. And you can also see on the radiograph that there is arthrogryposis. And the family did have pictures of the first baby, and we can see that there was ventricular megaly, Dandy-Walker malformation, agenesis of the corpus callosum. So, with this data in mind, because we had a good phenotype where we had 2 fetuses with arthrogryposis and multiple malformations, which were enlarged kidneys and CNS ventricular megaly and a Dandy-Walker malformation, we did trio whole exome sequencing was carried out. And we identified a homozygous splice site variant in a gene which was called the COG8 gene, which actually caused a metabolic disorder, which we never knew that we could see antenatally with malformations. This is a congenital disorder of glycosylation. And this was the third case reported in the world, and the first case in a fetus that was reported with malformations. And this was then published by us in the American Journal of Medical Genetics. So this was just to show you that how our knowledge, our database of knowledge is increasing by this technology. But also remember that this technology has to be used correctly. We have to have a good phenotype, we have to have the autopsy, we have to have the antenatal ultrasound details. If a pregnancy is terminated, it doesn't make sense if somebody notes that the fetus had multiple malformations. We want to know exactly what the malformations was. You need photographs, you need autopsy, you need all this information after appropriate consent from the family. That becomes imperative. So, what is the role of whole exome sequencing in prenatal testing? Prenatal whole exome sequencing has the potential to increase the ability to provide a precise diagnosis to the family, and this helps in counseling. Like in the last case, you're not going to wait till the third trimester for the malformations to come up in the ultrasound to guide them. Now that we have a molecular diagnosis, a definitive diagnosis, which fits into our phenotype, we know that we can do prenatal testing at 11 weeks of pregnancy because they still have 75% chance of having a normal baby. Or some families are now also opting for IVF and pre implantation genetic diagnosis. But all that is possible only once you have a definitive diagnosis. So it fills in the gaps for genetic disorders where the array is normal. So if an array is normal and we still strongly suspect a genetic disorder, then we can go forward for whole exome sequencing. However, it is important to remember that we use this extensively in postnatal life. But in prenatal life, in the infants, in the fetuses, it is still in its infancy. Data is being validated for the benefits and the pitfalls because we don't understand the fetal manifestations of a lot of disorders that we see postnatally. And the fetus has a limited phenotype, and there is limited experience in interpreting the data. Because remember that data needs good phenotype to interpret. And if we have a limited phenotype in the fetus, it can be a challenge to interpret that data. And because of these limitations, various societies, the ISPD, the SMFM, the Perinatal Quality Foundation, still do not recommend whole exome sequencing for routine use for prenatal diagnosis. However, they recommend that all patients who do receive it on a case to case basis need to receive extensive counseling from a provider with genetic expertise. They do recommend that it's still to be used on a research basis, but within the guidelines, various case scenarios have been defined where it can be used, but after counseling from a genetic provider. It has to be under the guidance of a genetics professional. So, to summarize everything that I've talked about, you identify an abnormality on the ultrasound because most of these technologies are used for that, which is there. So these abnormalities are identified in 2 to 3% of all feti. We need extensive pre-test education, counseling, and informed consent. Please don't underestimate these things because each one of them are very important. You do a karyotype, abnormalities are identified in 8 to 10% cases. You do a chromosomal microarray, abnormalities are identified in 6% of cases. In 20 to 80% of cases, we can do panel testing, exome testing, or genome testing. And remember, human, that means we give so this is just a standardized, the HPO terms is just standardized nomenclature, so that all over the world we use similar nomenclature that is fed in when we are doing the analysis of the data. If you have the same set of data and you don't give a good phenotype, you may not find anything. Very often, when we re examine that data with a good phenotype, we are able to identify the abnormality. So, that is the relevance of a good phenotype. You may not put it into the HPO terms, but you have to describe everything in detail. And remember that even for the fetus, we go from head to toe. So, this was what I had published in our society journal, the Journal of Fetal Medicine, on fetal dysmorphology, and how we can go in a systematic manner to make a diagnosis in prenatal life. So, to summarize, we have genetic investigations that are, we have genetic disorders that are chromosomal or single gene. The samples we can use are CVS, amniotic fluid, or blood for either. In for chromosomal disorders, if we want to do a fish or a karyotype, we take blood in heparin. If you want to do any DNA based study, we take blood in EDTA. That's the only difference. The microarray is a DNA based test. So there you would take blood in EDTA. Fish at karyotype, you take blood in heparin. And if a pregnancy is discontinued for any reason, a detailed fetal autopsy is important, and please save the samples. You must save the samples for DNA testing, because if they're not there, then it's a lost opportunity. So I would like to conclude my presentation by firstly saying thank you to everybody for joining me in this webinar, and also to my department, acknowledging my department and the role of each and everybody. We have a department strength of about 80 odd people, and everybody has a role in all the work that we take forward. Thank you very much. Um, I think we are now open for questions, and I see that there are some questions there, and I will try to answer them one at a time. Mm, oh, I'm trying to find the Q&A. Okay. So there is one question which says that if we have a father who's 59 with a wife who is 25, that's interesting, and no ossification of the nasal bone and rest of the fetus is normal, are we justified in asking for a fish and a microarray? Yes, you are. Um, because you're doing an invasive test, and remember that if because you have an absent nasal bone, and even when there is no real major abnormality, in 1 to 2% of cases you will find something in the microarray. So you are justified, but after appropriate pre-test counseling. So also remember that advanced paternal age is associated with abnormalities. We should not always blame the mom. And these are some of these de novo disorders like achondroplasia, Marfan syndrome. But I feel because we can't test for them, we don't scare them. But there is a small chance of these disorders. Please guide us for the test for Noonan syndrome, and how much time does it take for the results to come. So remember, there are very, very specific indications to do a test for Noonan syndrome. If you have an increased nuchal translucency, you will first exclude abnormalities of chromosomes. So you will do a microarray test. If the microarray is normal and your nuchal translucency is more than 3.5, now there are guidelines. There is a new paper that said in that you can test for Noonan syndrome. You do a targeted panel testing for Noonan syndrome. The turnaround time for most of these tests is still about 3 weeks. 3 to 4 weeks. So remember, you should have good enough time in your hands to take these tests forward. And again, I would like to reiterate that every prenatal test must have maternal cell contamination. And you know your lab is doing that if you've given EDTA blood sample of the mother. It needs that for the test. The validity of microdeletion on NIPT, it is still not valid. There is a lot of literature on it, but there is still a lot of false positive. So if you are looking for a microdeletion syndrome, please do. If there is a malformation on the ultrasound, there is no role for NIPT. That's very clear. If there is a malformation, or if there's any situation where you're testing for a microdeletion, please do a microarray test. Differences between 315K and 750K. So normally we use the 750K antenatally. Okay, we use the 750K, which is the Affymetrix platform. In the Agilent platform, we would use the 4x180K because this is a combination of CNVs and SNPs. The lower density ones are only copy number variations. So it will not pick up some of it. You have also have to go back and probably see when your microarray plate was made. Does it have the new microdeletion syndromes? So then you can use the smaller one because cost is the basic issue. We use the smaller copy number variations for our intrauterine deaths and fetal autopsies, unless we are strongly suspecting something where I would use a larger one. But there is really no role of the high density microarray. There's no role of that. It's still on a research setting. For mutation analysis, would you prefer CV or amniotic fluid? I'd prefer CV. It gives better DNA. Remember, if your sample is not good, the test validity is also low. So you can't be blaming the labs. So if you're looking for a single gene disorder, please do a CVS. What are the indications for fetal microarray? So, what are the indications for fetal microarray as a first line investigation? So, the ACMG and the SFFM put down the indications as more than one or more than one malformation in the fetus, intrauterine fetal death, or stillbirth, or if you're doing an invasive test for any indication that does not include a malformation, like you're doing it for a positive screen or an advanced maternal age. In that, also, you can do a microarray because in 1 to 2%, you can get abnormalities that are not identified on a karyotype. But remember, you need good pre test and post test counseling for the variations of unknown significance that are picked up, and you should have a good backup to counsel the families for those variations. Cornelia de Lange is de novo, the risk of recurrence is low. In science, we never say never because there is no never, there's no absolute. So we say that the risk of recurrence is low. In my experience, I've only seen one family where CDLK has referred, but most of them are de novo. How do you go about a couple with a normal antenatal screen with a previous indexed child with an undiagnosed genetic condition? Are we justified in doing an exome directly in the pregnancy? We are not. I've reiterated this over and over again in my presentation. If there is an indexed child with an undiagnosed genetic condition, number one, it has nothing to do with your antenatal screen because your antenatal screen is for Down syndrome. And you would recognize if that child had Down syndrome. So, an undiagnosed genetic condition could mean it could be chromosomal, it could be a single gene disorder. We don't know anything. You will not do any prenatal test. You will first do a microarray. You will first have that child examined. Then, depending upon what the clinical diagnosis is, the next level of genetic testing is done in the index child. Once something is identified in the index child, only then prenatal testing is done. And this should be very, very clear to everybody. Previous pregnancy has a 17 HSP3 hydrogenase deficiency. Okay, 17 beta HST. Okay. The baby is a male pseudohermaphrodite. How do we go about? So you have to have the molecular diagnosis here. Even if she's at 19 weeks pregnancy, by just taking out amniotic fluid, you wouldn't know what test to do. So I would quickly first test the affected child and then do the prenatal test. Advantages of QF-PCR over FISH. There are no advantages. They look for the same things, 13, 18, 21. Like I explained to you, if I'm doing a test for a monogenic disorder and I have a DNA sample, in that I would do a QF-PCR. Different labs have standardized different techniques in their labs, so you should get back to the lab where you're sending your samples. Hypoplastic nasal bone at 20 weeks. I would do a chromosomal microarray if chromosomal abnormalities have not been excluded. If chromosomal abnormalities have been excluded, I would not test for anything else because we don't know what else to test for. Hypoplastic nasal bone can be maybe absolutely normal, where the nasal bone is ossified later, or it could be some sort of a syndrome later in life, but we cannot test for that antenatally. What is the difference between whole exome sequencing and a clinical exome? Okay, so a clinical exome is like a panel test. It looks at about 5 to 6,000 genes. So, over 20,000 genes, all of them are not associated with human disease. We know that currently only about 4 to 5,000, about 5,000 odd genes are associated with disorders in human beings. So, a clinical exome is just targeting those. That's all. Isolated Blake pouch cyst, we would look at chromosomal abnormalities. 5% can be associated. Beyond that, nothing. Array is better than NIPT. The two are incomparable. Indications are totally different. Array is done when we have fetal malformations. When we have fetal malformations, you will not do an NIPT. Okay? If you have multiple malformations on the ultrasound, will you do whole exome directly? No, you will not do whole exome directly. You will first do chromosomes. That's the standard of care. You will do chromosomal microarray first, and then you will do whole exome. Depending, I mean, it's very difficult to give you a answer that you will do a whole exome for all malformations. It is on a case to case basis. Remember, the guidelines say it is not a recommended modality of testing. It is on a case to case basis. It is still in research use. So you would liaise with somebody who has some genetics expertise before doing the test. Hmm. What I wanted to know is it possible to send postnatal sample for fish and then if normal to get a microarray? So it depends upon the kind of sample. If it's an amniotic fluid sample, uh, then you could send it. But if it's say a product of conception, if it's a CVS, you could do a fish or a chromosomal um, or a QF PCR. Okay, I hope that answers your question. Why no MCC done for fish? Why no MCC done for fish? Um, that's a good question. It's not a DNA based test. Normally, we do maternal cell contamination for DNA based tests. If you are taking amniotic fluid, the possibility of maternal cell contamination is very low. It is only there if your amniotic fluid is blood stained. Okay. If you're taking a chorionic villus sample, you would need to separate the chorionic villi very, very carefully. Okay. And so you can separate the villi, they are separated under a microscope. So expertise is required there from the decidua. Role of mitochondrial karyotyping on the abortus. There is nothing called mitochondrial karyotyping. There is either a karyotype, there is a microarray that looks at abnormalities of chromosomes. Mitochondrial disorders is a whole group of disorders which occur because of abnormalities either in the mitochondrial genome or in the mitochondrial genes. So there is no role of mitochondrial karyotyping on the abortus. Often on picture we get report as contamination. Sorry, I can't understand that question. Obviously, they have tested for maternal cell contamination and they would have found that that sample has maternal decidua instead of chorionic villi. Where you would prefer fetal blood rather than amniotic fluid. So, fetal blood, well, yes, it's a very good sample. Again, you would do the maternal cell, you would do the Klehoff-Bethke test in the fetal blood if it's taken antenatally to make sure that it's fetal and not maternal. And that also works very well because you can do many more tests on fetal blood, especially in situations like non-hydrops fetalis, um, where you could look at the CBC, you could look at various enzymes. So it's a very good sample if you can give a good sample. Pathogenicity for low-level mosaicism. That's a very good question, Dr. Sangeeta. So, so when we do fish, we typically pick up mosaicism on fish. That's the best test to look for mosaicism because you can count up to 100 cells. You can't do it in any other thing. So, if the microarray has picked up some low level mosaicism, I would go back to my fish and see that. And up to 10% is normal because that is related to lab procedures. The lower the level of mosaicism, obviously it differs for different chromosomes. In some, it has no relevance. In some, very low, the lower the level of mosaicism, the more the normal cells, the fewer the abnormal cells, the better is the outcome. The more the abnormal cells, the fewer the normal cells, the worse. I mean, the fetus would be more affected. Let me not say worse. The fetus would be more affected. And it also depends upon the chromosome that we are looking for. So, again, this would have to be sorted out on a case to case basis. But as a general rule, more normal cells, fewer abnormal cells, the outcome is mild. In some situations, it could be close to normal, which is why I said it depends upon a case to case basis. Somebody wants again to understand the difference between an array CGH and a SNP with respect to the technology. So the array CGH is only copy number variations. It'll look at Williams syndrome, it'll look at 22q, it'll look at micro deletions, it'll look at all the known deletions and duplications. The SNP array, in addition, because there are SNPs, there are single nucleotides that are there, will look at additional things like triploidy. It will look at additional things like uniparental disomy, so that can give you a clue for disorders that occur because of imprinted genes, like Beckwith-Wiedemann, Prader-Willi, Angelman. And it'll also pick up to a higher extent mosaicism. So these are the advantages of the SNP array. But remember that most of the arrays today use a combination of both. So your 750K or the 4x180 is using a combination of copy number variants, CNVs, as well as SNPs. What should a pre-test and a post-test counseling include? It depends upon what you're doing it for. If you're doing it for an aneuploidy screen, it's different. If you're doing it for NIPT, it's different. If it's for microarray, it's what I've spoken about. So obviously, it is dependent upon the test that you're doing it for. There are 3 abortions. Yes, definitely, you would look at parents' chromosomes there. Recurrent neural tube defects, first I would ask whether they have taken periconceptional fulvite, because we know that after 1 NTD, the risk of recurrence is 5%, after 2, it's 10%. So that's the basic history to be taken. Look for additional abnormalities because neural tube defects can be a part of multiple malformation syndromes as well. So this was a continuation of a question with for that ambiguous genitalia. And the question here now she's asking is, it has been done, the fetus also has the same deficiency, then if the parents want, then you would terminate. Remember, these are not our decisions. Some people would say, no, I want to carry my pregnancy forward. You have to just explain what the disorder is, what are the outcomes of the disorder, what are the treatment options for that disorder, whether it's definitive, whether it is supportive, are the facilities available where they stay. Final decision of terminating or not terminating is that of the family. It is not that of the doctor. So we have a lot of common questions which I'm flipping through. And I also see that we are, oh, my laptop is also going to die. And I'm also seeing that we are 15 minutes past our timing. How would you counsel for increased heterochromatin for chromosome 9 or Y? These are normal variations. Okay, so these are not abnormalities. So the person is normal. Can you please detail imprinting disorders? So imprinting disorders are a group of disorders that occur because of a different genetic mechanism. They are called non-Mendelian disorders. And normally, in normal human beings, only one gene is active in them, the other gene is not active. So if any genetic mechanism knocks off that active gene, it will cause the disorder. That's why it's called imprinting disorders. Because in the normal situation, one gene is imprinted, which means that one gene is not active. An imprinted gene is an inactive gene. So that is the basic concept of imprinting. So if a child has Prader-Willi syndrome, so let me take an antenatal manifestation. So you have exomphalos, you've excluded chromosomal abnormalities. You would want to think, especially later if the baby is big and the tongue is protruding out, you would like to think about Wiedemann-Beckwith syndrome. Now that is an imprinted disorder. If I just do whole exome sequencing, I will miss Wiedemann-Beckwith syndrome. So we have a handful of such disorders which need different kinds of tests. They need what we call methylation sensitive MLPA, MSMLPA kind of test to look for them. So you have to be careful there. So it's the common imprinted disorders are Prader-Willi, Angelman syndrome, Wiedemann-Beckwith, Russell-Silver syndrome. These are some of the common imprinted disorders. The rest are very rare in fetal life. So I think we can stop there. Harish, is there some message from somebody or can we close the webinar? I would like
Ma'am,
to
we can
thank.
close.
If you are done with everything,
Okay.
if you're done with all
So
the
I,
questions, we can close it. Yes.
so I would really like to thank the audience and for this session. It's a new feeling to be interactive on a Q&A, but it's nice nonetheless. So thank you very much, and we'll see you some other time. Bye bye.